Hello, my name is Shez Basaria. I'm a faculty in the Division of Endocrinology in the section of Men's Health, Aging, and Metabolism. And my topic today is testosterone therapy in men. These are my disclosures. So I have divided the talk into four broad outlines. Initially, I will discuss the physiology of the hypothalamic pituitary gonadal axis, also known as the HPG axis, followed by clinical manifestations and signs of male androgen deficiency. Then I'll take you through diagnostic workup and then cap it off with benefits and risks of testosterone replacement. So this cartoon represents the HPG axis. We know that everything starts here in hypothalamus, where a group of neurons make GnRH that travels down the pituitary stalk and acts on cells in the anterior pituitary known as gonadotropes. These cells in turn produce two hormones, LH and FSH. LH acts on the Leydig cells of the testis to produce testosterone, and FSH acts on seminiferous tubules and Sertoli cells and promotes spermatogenesis. In general, testes secrete 3 to 10 milligrams of testosterone daily, which roughly translates into serum levels between 300 to 1,000 nanograms per deciliter. Now, based on this range, in the past, arbitrarily, it was determined that 300 nanograms per deciliter is the lower limit of normal. But as you will learn in this talk, that the lower limit of cutoff is much lower than 300. There is diurnal rhythm of testosterone secretion, which is most evident in young, healthy men. And the peak levels occur in the early hours of the morning. And that's the reason when we evaluate a man for hypogonadism, they're asked to come in the morning hours for their blood test. Now, testosterone acts via androgen receptor and has a lot of actions on muscle, bone, and brain. It is responsible for bone strength, and it's anabolic to muscle. It promotes erythropoiesis, it gives sexual desire, but it's a prohormone because acting itself is one thing, but it is also metabolized into two active metabolites. Via 5-alpha reductase, it's converted to DHT, which acts via the same androgen receptor, and it's responsible for development and growth of the external genitalia and prostate. The role of DHT in postnatal life is controversial, but we do know that it is targeted when men present to us with BPH, and finasteride and other 5-alpha reductase inhibitors are used to shrink the prostate gland. Testosterone is also converted to estradiol via enzyme aromatase. Estradiol is not only a female hormone, it's a very important hormone in men, and it's responsible for bone strength, and it's even more anabolic to bone than testosterone itself. It also plays a role in male sexuality and is responsible for epiphyseal closure. Now, testosterone circulates in the blood in different forms. Approximately 1 to 2% of testosterone circulates as free form, and this is considered to be the active part of testosterone which goes inside the cell and acts on the nucleus and works in the transcription process. Around 50 to 60% is bound to albumin, and this binding to albumin is rather loose. So in times of need during tissue transit, testosterone can easily dissociate from albumin and becomes available to the tissues. And the remaining 40% is bound tightly to SHBG, or sex hormone binding globulin. So sometimes when you read in the literature the term bioavailable testosterone, it's basically the combination of free testosterone and albumin-bound testosterone, which is labeled as bioavailable. When I will take you through the evaluation of a hypogonadal man, you will see that we mostly rely on total testosterone and in some circumstances, free testosterone. We do not know what the lower limit of cutoff for bioavailable testosterone is, and that is why it's not used in the clinics when we see our patients. And it's also very difficult to measure by various laboratories. Now, definition and etiologies. This cartoon is rather simple but conveys the message. On the left, you see the cartoon of the normal HPG axis that we discussed a few slides back. In the middle is a cartoon depicting primary hypogonadism, which means problem lies at the level of the testis. There is decreased production of testosterone, loss of negative feedback, and in turn, there is increased secretion of gonadotropins. Also, in primary hypogonadism, when testes are affected, spermatogenesis may also be compromised. And another way to label this primary hypogonadal state is hypergonadotropic hypogonadism. On the right, you see a cartoon depicting secondary hypogonadal state, where problem resides either at the level of the hypothalamus or pituitary. There is decreased secretion of gonadotropins, decreased stimulation of the testes, and the end result is low testosterone and suppression of spermatogenesis. This is also known as hypogonadotropic hypogonadism. Now, in terms of clinical manifestations, it depends when hypogonadal state sets in. So on the left part of the slide, you see primary hypogonadal state and various etiologies, congenital and acquired, and on the right, secondary hypogonadism, congenital and acquired. Here, I will take you through the various etiologies. In terms of congenital forms, Klinefelter syndrome is one of the most common genetic conditions that can result in androgen deficiency and infertility. But there are some congenital states which only affect spermatogenesis. Y chromosome microdeletion is one such state that men are normally virilized, but they may present with infertility or subfertility. In terms of acquired causes of primary hypogonadism, it includes testicular trauma or torsion, testicular radiation, mumps, and other types of orchitis, chemotherapy, in particular alkylating agents, cyclophosphamide, chlorambucil, and certain infiltrative diseases. So any insult or damage that happens at the level of the testis can result in primary hypogonadism. In terms of secondary hypogonadism, again, congenital causes include Kallmann syndrome, where there is isolated deficiency of hypogonadotropic hypogonadism, and there are wide spectra of this condition. Some men may present with anosmia, some hyposmia, and some normosmia. But the bottom line is that testosterone levels are significantly low, and the gonadotropins are also low or inappropriately normal. In terms of acquired causes, hyperprolactinemia of any etiology can result in central hypogonadism because prolactin suppresses GnRH synthesis and release. Pituitary damage due to any reason, either tumors or infiltrative conditions or apoplexy, head trauma that results in stalk injury, medications. With the opioid epidemic, we are seeing such patients more often in our clinic. Opioids are potent suppressors of the gonadal axis, and even young men on opioid analgesics may present with testosterone levels which are in the castrate range. And supraphysiological doses of glucocorticoids can also suppress gonadal axis. These are some of the examples of secondary hypogonadal state. This patient presented with panhypopituitarism and had a thickening of the stalk. The patient also had diabetes insipidus, and he was found to have sarcoidosis. So this is one type of hypogonadal state due to infiltrative disease. And another condition which is also seen rarely, but one should be cognizant and in the evaluation of a hypogonadal man, iron studies is one thing that we usually recommend. And this patient presented with central hypogonadism and had hemochromatosis. On the right side, you see MRI of a normal man, and this is the density of the pituitary that you see on the MRI. While this is a man with hemochromatosis, and you can see that the density of the pituitary gland is rather black, which is similar to air in the sphenoid sinus. So these are important things to consider when you see a patient who has secondary hypogonadism. In terms of clinical features, as I mentioned briefly, it depends when the disease sets in the prepubertal age group or post-puberty. And I will take you through that slide in a moment. But it is important as clinicians for us to appreciate which symptoms are considered specific for androgen deficiency and which are non-specific. This slide is adapted from the recently published Endocrine Society guidelines on evaluation of male androgen deficiency. And suggestive symptoms include reduced libido and reduced sexual activity, decreased spontaneous erections, usually encountered in the early morning hours, incomplete or delayed puberty, gynecomastia, loss of body hair, testicular atrophy, infertility, and hot flashes. Important to appreciate that symptoms such as decreased energy, reduced muscle bulk, increased body fat, poor memory, or brain fog that majority of our patients present in the clinic are not specific for androgen deficiency. So one should be cognizant, and it is important when testosterone levels result back robustly normal, one should consider other etiologies for these symptoms. This tells you when a person presents with androgen deficiency and how dramatic manifestations are. So symptoms and signs are more dramatic when a person is prepubert or has encountered androgen deficiency prior to reaching puberty. These patients have testicular atrophy, micropenis, underdeveloped scrotum, anosmia may be present. Unicoidal proportions, arm span is 5 centimeters more than the actual height, decreased body hair, high-pitched voice, and osteoporosis and low muscle mass. In post-pubertal onset states, symptoms and signs may not be that dramatic, but some of the specific symptoms, as I mentioned, decreased libido and spontaneous erections, testicular atrophy, vasomotor symptoms, gynecomastia, and osteoporosis. But these men generally have normal skeletal proportions, normal penile length, normal voice, and normal prostate size. This is Prader or pedometer, which we carry in our pockets when we go to the clinic. These beads represent testicular volume. Normal volume is considered 15 cc's or higher. And these smaller beads are the beads that you see in patients who have Klinefelter syndrome or Kallmann syndrome. Sometimes profound testicular atrophy in the aftermath of mumps or chitis can also result in significant testicular atrophy. And the way to examine patients is that you glove up and take one testis on the side of the scrotum with one hand, and you flip the beads with the other hand, and whatever approximates best, that is your approximate testicular volume. It is a crude method, but it is associated or approximates very well with sonographic volume measurements. One should be cognizant that hyperprolactinemia due to any etiology is an important cause of secondary hypogonadism. And although galactorrhea is more commonly seen in women with prolactinomas than men, but men can also present. And this is one of my patients who presented with prolactinoma and had galactorrhea. Huge prolactinoma with prolactin in the range of 23,000 after dilution. And after 2 years of treatment with dopamine agonists, there was significant reduction of the tumor size. So it's important to know the etiology because treatment might be different. You won't give testosterone to these men. You try to control the cause, which is resulting in testosterone deficiency. Diagnostic workup. It is important to appreciate that evaluation and diagnosis of male androgen deficiency should be done in an ambulatory setting. The reason being when patients are hospitalized and are acutely or subacutely sick, there's an adaptive response of the body that testosterone does go down in times of sickness. And that's why it is good to postpone evaluation until you see these patients in your clinic. Important to make sure that the signs and symptoms are ascertained. Total testosterone in the morning, fasting with a reliable assay is the first step. If total testosterone is less than 264, which is the new cutoff suggested by Endocrine Society guidelines, then one could potentially proceed with further workup, which involves a repeat morning total testosterone. So a single testosterone is not sufficient. You at least should have two values. And if it is again less than 264, then one can move forward to measure gonadotropins to determine whether a person has primary hypogonadism. If that's the case, one should consider iron studies, and you might wish to do karyotyping to rule out Klinefelter syndrome. If it is secondary, then prolactin measurement, iron studies again, because it can cause both primary and secondary hypogonadism. One should make sure that you have medication lists and they are not on opioids or glucocorticoids. And based on the clinical setting, you may decide to measure other pituitary hormones and may wish to consider MRI if you think it's clinically indicated. Now, I mentioned here free testosterone. Usually, total testosterone is the best screening test, but there are some medical conditions which I will mention in the next few slides where there are alterations of serum SHBG concentrations. In those situations, free testosterone would be of great value because total testosterone might be unreliable. So before discussing those conditions, I have a question for you. Which of the following conditions results in reduced serum sex hormone binding globulin levels? A, hyperthyroidism, B, liver disease, C, obesity, D, HIV disease. And the correct answer is obesity. And I'm sure that many of you may have thought about this condition. Obesity results in insulin resistance, and hyperinsulinemia suppresses SHBG synthesis in the liver. And this is one condition in which total testosterone might be low, but free testosterone is often normal. So one runs the risk of overdiagnosing a person with androgen deficiency if you do not check free testosterone. All the other conditions are associated with increased SHBG levels. So these are the conditions. Let's talk about those states which result in increased levels of sex hormone binding globulin: aging, thyrotoxicosis of any etiology, hyperestrogenemia, liver disease, HIV. Here, a person might have androgen deficiency with classic symptoms, but SHBG levels might be so high that total testosterone may be spuriously normal. And if you don't measure free testosterone, you may miss the diagnosis. But most concern we have are with these conditions, which are on the right side of the screen. Conditions which result in decreased levels of SHBG. Obesity, insulin resistance, and diabetes are extremely common. And you will have patients presenting with non-specific symptoms, and total testosterone would be low because of low SHBG. And if you just stop there, you will overdiagnose the patient with androgen deficiency and you will start treating them. What one should do in these conditions is pause and take one step further and measure free testosterone to make sure you make an accurate diagnosis. And often you rule out androgen deficiency. Now, measurement of free testosterone, the gold standard method is equilibrium dialysis. Many commercial labs, such as Quest, LabCorp, and Mayo Clinic Lab, which has a contract with Brigham and Women's Hospital because our labs go to them, they measure free testosterone with equilibrium dialysis and total testosterone by liquid chromatography mass spectrometry, both gold standard. So in some institutions, providers are lucky enough to have access to the gold standard methodologies. But if you do not have free testosterone measurement available by equilibrium dialysis, calculation of free testosterone is generally reliable. What you need is a total testosterone by mass spectrometry, and both commercial labs, Quest and LabCorp, are now offering that. You check that, you measure SHBG concentrations, and you should have an albumin. And if you Google, there's a formula available online, free testosterone calculator. And if you punch in these values, you will get free testosterone. And it is generally believed that 50 picograms per ml is the lower limit of cutoff for free testosterone. What I would encourage you not to do is check free testosterone in your own hospital laboratories, because analog assays are used to measure free testosterone, and it can be either under or overestimated by around 10 to 15%. So either use equilibrium dialysis or do calculation on your desktop with the free T calculator. Now, once you have made the diagnosis of androgen deficiency and you are thinking about testosterone replacement, you should make sure that there are no contraindications. And they include metastatic prostate cancer, breast cancer, prostate nodule or induration on baseline DRE, unless urology evaluation has been performed and a person has been deemed safe or biopsies have been negative. Baseline PSA more than 4 in Caucasian men and more than 3 in African American men, and those men with first order relatives with history of prostate cancer. Unless evaluation is negative, one should consider consulting with urology before initiating treatment. If urology has approved or cleared those men for treatment, then you can safely proceed with treating them. Severe lower urinary tract symptoms, erythrocytosis at baseline, uncontrolled CHF are also contraindications. Testosterone causes salt and water retention. So if CHF is uncontrolled, you can tip them over and exacerbate it. And a person who has immediate desire for fertility, one should rethink about starting testosterone, because testosterone can suppress the axis further, and there could be further decrement in sperm count. Now, in terms of modalities of testosterone replacement, there are plenty of modalities available. I will only touch upon 3: injectables, patch, and gel. There are other options now available, such as nasal testosterone, ultra-long-acting injectable testosterone, as well as oral testosterone, which was recently approved. Injectable short-acting esters, such as testosterone enanthate and cypionate, have been available for around 80 years. And the dose, which is generally chosen, is 200 milligrams every 2 weeks. This is a dose of convenience. This is not a physiologic dose, because as you can see on this graph, after you inject testosterone, the levels can go extremely high, and then they steeply come back into the lower limit of normal range, or sometimes dip below lower limit of normal after 2 weeks. So there are peak and troughs, and this is known as roller coaster pharmacokinetics. What we usually recommend are weekly testosterone injections, but at smaller dosages, 75 milligrams a week for older men, 100 milligrams per week for younger men, and the levels are plateaued, as you can see. One should check testosterone level midway between the injections. Advantages: it is very inexpensive, and you can teach patients to administer it themselves, or their spouses or family members can administer it intramuscularly. And disadvantages: variable pharmacokinetics if you give at this dose, fluctuation in mood and libido, because you can see the roller coaster phenomena, and sometimes patients might present with pain at the injection site, which is very uncommon. Transdermal testosterone patch is available. Starting dose is 4 milligram. It is also available in a 2 milligram size, and 8 milligram is the maximum dose that you can administer, and it's applied nightly to upper arm, back, or thigh. You should monitor on-treatment testosterone levels 3 to 12 hours post-application. It is convenient. It mimics circadian rhythm, because as you can see, if you apply it at night, and that's the usual recommended time, around 10 o'clock, the levels increase slowly and reach reach its peak in the early hours of the morning, so mimic circadian rhythm. Disadvantage, during summer months, it can fall off because of sweating, so problems with adherence. And the main disadvantage is skin irritation, which can be seen in one-third to two-thirds of these individuals. Skin irritation can present as simple allergic contact dermatitis or sometimes more blister type of reaction. But if a patient likes this formulation and the levels achieved are in the physiologic range, then you can circumvent this problem by prescribing a 0.1% triamcinolone cream, which a person can apply on the skin where they are thinking about putting the patch on. It cuts down irritation significantly and does not affect absorption of testosterone. And lastly, we have testosterone gels. We have a 1% gel, 1.62% gel, 2% gel available, which are applied daily at the same time of the day to non-genital skin. This is the cartoon which describes the areas of application. One should check testosterone levels anytime 1 week after initiating therapy. Advantages include that it's convenient, mimics circadian rhythm, good skin tolerance, but the disadvantages include potential of transmission to spouse and even to kids. You have cases of precocious pseudopuberty in some kids when dads or granddads may have picked up their kids without covering that area where they had applied the gel. So it's good to cover that area with a cloth. Keep it open for 10 to 15 minutes after applying it so it dries. Then you can wear your shirt on and make sure that that shirt remains on if you are picking up a child. Skin irritation is much less common. And these are the pharmacokinetics with 5 milligram and 10 milligram gels. In terms of benefits, there are quite a few benefits of testosterone replacement. The green ones are the benefits which are well known in those men who have organic hypogonadism. By that, I mean structural problems related to hypothalamus, pituitary, or testes when testosterone levels are clearly low. In young men who present, testosterone can improve masculinization or virilization, muscle mass, sexual function, and bone density. The gray areas, cognition, depression, quality of life, and physical function, I have put those in because there is a tendency nowadays to even prescribe testosterone to those older men who present with age-related decline in testosterone, where there is nothing organically wrong with hypothalamus, pituitary, or testes. And data have shown that testosterone replacement does not improve memory, does not necessarily improve depression. Quality of life data are mixed. And although it improves muscle mass and muscle strength, it has not always translated into improvement in physical function, which we desire in older men. Now, before moving to the adverse effects of testosterone replacement, I have another question for you. What is the most common side effect observed in clinical trials of testosterone replacement? A, thromboembolism, B, erythrocytosis, C, prostate cancer, D, obstructive sleep apnea. And I'm sure many of you have thought about this. The correct answer is erythrocytosis. When you see clinical trials of testosterone replacement, men randomized to testosterone usually develop more erythrocytosis compared to men in the placebo arm. And before erythropoietin was discovered, androgens was the treatment for many types of refractory anemias. There are mixed data on thromboembolism. Some studies have shown that it might promote, but quite a few have shown that it does not. So the jury is out. Testosterone does not cause prostate cancer, and in trials of testosterone replacement, men on testosterone were not found to have higher incidence of prostate cancer compared to placebo, but no trial has been powered to detect it. So one has to be cautious. And mixed data in terms of worsening of obstructive sleep apnea with testosterone. So these are the adverse effects. Some of them I mentioned in the previous slide, but today I'm just going to briefly touch upon three: erythrocytosis, prostate, and cardiovascular. So in terms of erythrocytosis, As I mentioned, if you look at clinical trials of testosterone replacement, uh, hematocrit greater than 50 or 52%, this is the side effect which is seen most often in men randomized to testosterone versus placebo compared to any other side effect. So, Endocrine Society has come up with some guidelines. One should make sure that a person does not have erythrocytosis to start with, baseline hematocrit greater than 48%, or those who live in high altitudes such as Colorado. If your hematocrit is greater than 50, one should make sure that you evaluate for underlying sleep apnea or hypoxic condition before you start treatment, because it's going to go up with testosterone replacement. Once you have started a person on testosterone, hematocrit should be checked at 3 to 6 months after treatment initiation and then annually. Men who are older and who are on high doses of injections, those 200 milligrams every 2 weeks, those are the ones at the highest risk of erythrocytosis. Once you encounter erythrocytosis, defined as hematocrit greater than 54%, you should evaluate for hypoxia and sleep apnea, stop treatment or pause treatment to make sure that hematocrit normalizes, and you can reinitiate at a lower dose. One should also use the option of therapeutic phlebotomy if you want to bring down hematocrit levels rapidly. In terms of prostate, testosterone does not cause prostate cancer. We know that from various studies, although they were not designed to look at incident prostate cancer as the primary outcome. But there's always a concern because presence of occult prostate cancer is very common in older individuals. And the theoretical concern has always been that if we start testosterone to these men, and if they have an occult focus, would it get exacerbated? This concern remains theoretical, but basically it gives us a pause and makes sure that we are monitoring our patients, especially older age group patients, very closely if they need testosterone replacement for any reason. So Endocrine Society guidelines suggest that no screening is needed with PSA for men who are under 40 years. So if you have a young man who is hypogonadal and you need to start testosterone, you do not necessarily need to measure PSA prior to initiation of treatment. But in men 55 to 69, and if a man is at higher risk, even starting at age 40, you should consider, and you could consider checking PSA. Men with these contraindications that I have touched upon, one should counsel against testosterone therapy. But if a person does not have contraindication and you have started testosterone replacement, PSA can be checked at 3 months and then 12 months post-treatment, and then based on age and race recommendations. So usually in clinics, after this time point, we do it annually. One should cease treatment if you detect a nodule, which needs to be evaluated, or if there is a delta PSA change greater than 1.4 nanograms per ml, because this delta cannot be explained by PSA assay variation. So this is something which should trigger further evaluation. And if the absolute PSA goes greater than 4, this does not mean that they have cancer. This simply means that you should be cognizant that they need more evaluation, and you can consult your urology colleagues. Once they are evaluated and cleared by urologists, then you can safely continue treatment. And lastly, cardiovascular disease, and this is the most controversial area, but I would say rather easier to address at this point because there are no concrete data suggesting that testosterone can lead to cardiovascular disease, nor concrete data suggesting that it is safe. There are some studies that have shown increased cardiovascular events in men who got testosterone compared to placebo. There are equal number or even larger number of studies that have shown that testosterone does not exacerbate cardiovascular disease. These are meta-analyses of various clinical trials, and if you look at the spread, it goes in various directions. Many of them are neutral. Some of them do suggest increased risk. And the reason this variation is because cardiovascular events have not been the primary outcome of even a single published testosterone trial. And all these trials were not powered to evaluate cardiovascular events and lacked structured adjudication processes. So, what I tell my patients is that the jury is out. We do not know whether it causes cardiovascular disease or not, but I explain them symptoms of cardiovascular disease, that if you have stroke like symptoms such as weakness or dysarthria, or if you have chest pain, or if you have shortness of breath, one should be cognizant that it could be related to testosterone or it may not be, and one should seek immediate evaluation. So unless more data are available, all we can do at this point in time is educate our patients that this is a possibility, but one should not deny treatment to those individuals who truly have androgen deficiency. So to conclude, diagnosis of hypogonadism should be made in a symptomatic patient who consistently has low serum testosterone levels. Testosterone should be measured in the morning hours in a fasting state on at least 2 occasions with a reliable assay. Consider measuring free testosterone in men with suspected SHBG abnormalities. And I would recommend equilibrium dialysis or calculate it yourself after checking total testosterone and SHBG and albumin. Choice of testosterone replacement modality should be based on patient preference, cost, availability, and formulation specific properties. Testosterone replacement in older men results in modest benefits, but it does result in good benefits in younger men and in those small portion of older men who truly have organic disease, profoundly low testosterone levels. Testosterone replacement in older men, we do not know in terms of cardiovascular and prostate safety, and we have to educate them and follow them diligently. And in addition to monitoring adverse effects, we also have to continuously monitor benefits to make sure that they are indeed benefiting, considering the symptoms that they had presented with. So this concludes the presentation on testosterone therapy in men. I appreciate you paying attention, and I'm thankful to the organizers of this meeting for inviting me.